Welcome, everyone. I'm Fariha Mujibuddin from the Integrated Care Resource Center, or ICRC. Thank you for joining us today for this webinar on state contracting with D-SNPs. This webinar is the third in a series of ICRC webinars for states on D-SNP contracting. The first webinar provided an introduction to D-SNPs and D-SNP contracting, and the second webinar focused on contracting strategies for integrated D-SNPs. Today's webinar will focus on ways that states can use contracts with D-SNPs to advance state goals and improve coordination and quality of care for D-SNP enrollees. Slide 2, please. Before we get started, I'd like to quickly go over a few logistics. For those of you joining by phone, you can view the slides by logging into Zoom. You can find the directions for doing that in the calendar appointment for today's webinar, which you should have received via emailing after registering. We will be recording today's webinar so you can revisit the presentation or share the recording with colleagues who are unable to join. We will send you a link to that recording and the slide deck soon, and we will also post the slides and recording on the Integrated Care Resource Center website. To eliminate background noise, all attendees' phone lines will be muted during today's presentation. We will have a Q&A segment at the end of today's webinar, but we'll keep the phone lines muted. So we ask you to submit questions through the Q&A icon at the bottom of your screen. You can submit your questions at any point during the webinar. If you'd like to use the closed captioning feature, click on the More Options button in the Zoom toolbar at the bottom of the screen and select the Captions option. You are also able to edit the caption settings to adjust the text size by going into the Subtitle Settings option. Slide 3, please. This webinar series on contracting with D-SNPs is part of a suite of ICRC resources for states on improving coordination of Medicare and Medicaid benefits for dually eligible individuals. You can find recordings and slides from past ICRC Working with Medicare webinars, including all 3 of the webinars in this D-SNP contracting series, on the ICRC website at integratedcareresourcecenter.com. We also have a variety of technical assistance briefs and other tools on the ICRC website that cover a variety of Medicare-related issues that are important to states, including several resources specifically on contracting with D-SNPs. Finally, you can also sign up on the ICRC website to receive email alerts about policy and program changes related to dually eligible individuals. Slide 4, please. Since we're going to spend today's webinar delving further into state contracting with D-SNPs, we wanted to take a moment and review why states contract with D-SNPs in the first place. D-SNPs are a specialized type of Medicare Advantage plan that only enrolls dually eligible individuals. D-SNPs must offer certain benefits that regular Medicare Advantage plans are not required to offer, such as model of care and care coordination services that are tailored for D-SNP enrollees, plan benefit packages and supplemental benefits that are designed specifically for dually eligible populations, and enrollee advisory committees that solicit input from D-SNP enrollees about the ways that the plans can improve care. D-SNPs must also always coordinate Medicaid benefits, and in some cases, D-SNPs may cover Medicaid benefits for their enrollees as well. In 2024, nearly half of dually eligible individuals nationwide were enrolled in D-SNPs, a result of tremendous growth in D-SNP enrollment in recent years. Slide 5, please. State Medicaid agencies have an important role to play in promoting greater alignment between Medicare and Medicaid coverage and processes for people enrolled in D-SNPs. Because D-SNPs must hold contracts with both CMS and the state that they operate in, state Medicaid agencies can use their contracts with D-SNPs to influence the level of Medicare-Medicaid benefit integration delivered in D-SNPs, as well as how care is coordinated for D-SNP enrollees. You can also use these contracts to advance specific state goals aimed at improving quality of care for dually eligible individuals. Slide 6, please. I'll kick off today's webinar by introducing our presenters and summarizing a few key takeaways from parts 1 and 2 of this webinar series. After that, other members of our ICRC team will describe how state requirements can be used to promote integration and enrollment into integrated D-SNPs, how state Medicaid agency contracts with D-SNPs, commonly referred to as SMACs, can be used to advance other state goals, and we'll also review state monitoring and oversight of D-SNPs. Finally, we'll wrap up with questions and answers. Slide 7, please. During today's webinar, you'll hear from 4 ICRC staff members. I'm Fariha Mujibuddin from Mathematica, and I will present the first segment of today's webinar. We have 2 substitute presenters today. Erin Weir-Luckmani from Mathematica will be presenting our second section on behalf of Emily Costello. Then Diane Beaver from Mathematica will present the third segment, followed by Ryan Stringer from Mathematica, who will present our final segment on behalf of Nita Joseph. Slide 8, please. Before we dive into new content, I'll provide a brief overview of key concepts and takeaways from the previous 2 webinars in this state contracting series. Recordings and slide decks from parts 1 and 2 are available on the ICRC website and linked on slides 12 and 13 of this presentation. Slide 9, please. D-SNPs must have a state Medicaid agency contract, or SMAC, with each state in which they operate, in addition to contracts with CMS. Federal rules require that all D-SNPs have at least certain minimum elements in their SMACs with states. States may include additional state-specific requirements in these contracts to improve administrative, clinical, and financial integration for enrollees. Later in today's presentation, we'll provide some examples of SMAC requirements states may consider to advance integration of Medicare and Medicaid benefits and related state goals. When executing contracts with D-SNPs, it's important for states to be aware of key dates in the Medicare Advantage contracting process. ICRC has developed a tool highlighting these dates for states, which can be found at the link in the box on this slide. Slide 10, please. There are 3 levels of D-SNP integration. At the most basic level, coordination-only D-SNPs, also known as CO D-SNPs, are required to at least coordinate Medicaid benefits. They must also alert the state of hospital or skilled nursing facility admissions for a group of designated high-risk, full-benefit, dually eligible enrollees. While some CO D-SNPs may cover some Medicaid benefits for their enrollees, CMS does not require these D-SNPs to cover any particular Medicaid benefits. State policy drives the level of benefit integration achieved by these D-SNPs. Highly integrated D-SNPs, also known as HIDE-SNPs, must cover Medicaid behavioral health benefits and/or long-term services and supports, also known as LTSS. Fully integrated, or FIDE-SNPs, offer the highest level of integration. To qualify as a FIDE-SNP, a D-SNP must operate with exclusively aligned enrollment, also known as EAE, cover a comprehensive set of Medicaid services, and meet additional regulatory requirements detailed on this slide. Finally, since all FIDE-SNPs qualify as applicable integrated plans, or AIPs, they must also use an integrated health risk assessment and an integrated member ID starting in 2027. Slide 11, please. On the previous slide, I mentioned that all FIDE-SNPs are AIPs. AIPs are D-SNPs that are a FIDE-SNP or a HIDE-SNP that operates with EAE, or a CO D-SNP that operates with EAE and covers certain Medicaid benefits, including nursing facility services, home health services, and/or medical supplies, equipment, and appliances. In all cases, AIP enrollees receive at least some Medicaid benefits from the D-SNP or an affiliated plan offered by the same parent organization. This is because AIPs operate with EAE. EAE occurs when the state contract limits enrollment in the D-SNP to full benefit dually eligible individuals who receive their Medicaid benefits from either the D-SNP or an affiliated Medicaid managed care plan offered by the same parent company as the D-SNP. Slide 12, please. Now, I'll briefly note the topics that we covered in depth in the first 2 webinars of this series. We encourage you to visit the links to those 2 webinars for more detail on these topics. In the first webinar, we provided a brief introduction to dually eligible individuals and data on the increasing number of dually eligible individuals enrolled in D-SNPs in recent years. We then explained what D-SNPs are, how D-SNPs differ from other types of Medicare Advantage plans, and minimum federal requirements for all D-SNPs. We also described the minimum requirements for SMACs, as well as some additional requirements that apply to integrated D-SNPs. We closed the webinar with information about new rules that will apply to certain D-SNPs in 2026, 2027, and 2030. Slide 13, please. In our second webinar on D-SNP contracting, we summarized two key contracting strategies states can use to contract with D-SNPs for coverage of Medicaid benefits. Directly capitating D-SNPs to cover Medicaid benefits for D-SNP enrollees, or aligning D-SNPs with affiliated Medicaid managed care plans offered by the same parent organization as the D-SNP. We provided specific state examples for each of these strategies and noted that some states may even consider using both of these strategies in different circumstances. In this webinar, we also explained that the federal Medicaid managed care regulations at 42 CFR Part 438 apply to D-SNPs that cover Medicaid benefits, and we shared some examples of key rules that states may want to keep in mind when developing integrated D-SNP programs. Finally, we summarized several Medicaid procurement considerations for states that have or are planning to implement integrated D-SNPs. We shared some key Medicare Advantage dates that are important to keep in mind. We described Medicare resources that states can use to assess Medicare performance and Medicaid procurements that affect integrated care programs. And we discussed the ways that states can plan for and address unexpected events in the procurement process. The link to the second webinar is provided in the green box on this slide. Now I'll pass it to my colleague, Erin, to talk about how states can use SMAC requirements to promote integration and enrollment in integrated D-SNPs. Slide 14, please.
Thanks, Fariha. So I'm now going to discuss several options that states can use to advance D-SNP integration and also promote enrollment into integrated D-SNPs. Slide 15, please. In order to support D-SNP integration and promote enrollment into aligned plans, states may consider requiring that D-SNPs operate with exclusively aligned enrollment. States may also want to consider allowing or requiring D-SNPs to use default enrollment. And some states may also want to consider requiring D-SNPs to use separate plan benefit packages under a particular D-SNP contract or contracts to serve different groups of duly eligible individuals. I'm going to discuss each of these three policy options in the slides that follow. Slide 16, please. So first, I'm going to discuss the option of requiring D-SNPs to operate with exclusively aligned enrollment, or EAE. However, before we dive into EAE, let's first define aligned enrollment. Aligned enrollment occurs when a duly eligible individual is enrolled in a D-SNP and a Medicaid managed care plan offered by the same parent company in the same geographic area. In the graphic on the left side of this slide, we have a landscape where D-SNP enrollees can be both aligned or unaligned. In this specific landscape, a duly eligible individual could receive Medicare benefits from company A and receive Medicaid benefits from company B. That is considered unaligned enrollment. However, other people in this graphic may be receiving Medicare benefits and Medicaid benefits, both from company B. That is considered aligned enrollment. In the graphic on the right side of the slide, all D-SNP enrollees have aligned enrollment because anyone who receives D-SNP coverage from company A also receives Medicaid coverage from company A, and so on. Slide 17, please. States have the option to require D-SNPs to operate with exclusively aligned enrollment, or as I said, we sometimes call this EAE for short. EAE occurs when the state contract limits enrollment in a D-SNP to full benefit, duly eligible individuals who receive Medicaid benefits from the D-SNP or from an affiliated Medicaid managed care plan offered by the same parent company as the D-SNP, as you saw in the aligned enrollment depiction on the previous slide. EAE facilitates use of several strategies that help to integrate coverage and support navigation of Medicare and Medicaid benefits, such as fully integrated enrollee materials, single ID cards, and unified appeal and grievance processes. For more information about exclusively aligned enrollment, you can see ICRC's resources, to which we provide a link on the right side of this slide. Slide 18, please. Another way that states can facilitate enrollment into integrated D-SNPs is through default enrollment. Default enrollment enables qualifying D-SNPs to enroll people who are currently enrolled in a D-SNPs affiliated Medicaid managed care organization into the D-SNP when those individuals become newly eligible for Medicare. To qualify for default enrollment, a D-SNP must obtain approval from the state and CMS, and the D-SNP must also meet specific qualifications that are defined in federal regulations, such as having a minimum overall quality rating of at least 3 stars and not having any CMS prohibition on new enrollments. D-SNPs that are interested in default enrollment have to first receive approval from the state, and then they have to submit an application to CMS and have that application get approved. Again, default enrollment is only available when a D-SNP has an affiliated Medicaid MCO as an option for Medicaid-only beneficiaries who are in that MCO and who become duly eligible by qualifying for Medicare later. Those people can be default enrolled into the D-SNP when they first become eligible for Medicare. For more information about default enrollment, you can see our tip sheet on that topic, which is also in the box on the right side of this slide. Slide 19, please. States that are working to promote aligned enrollment in D-SNPs may sometimes want to consider requiring that D-SNPs divide up their duly eligible enrollee populations into different plan benefit packages, or PBPs. A Medicare Advantage plan benefit package is a specific set of health benefits offered at a uniform premium, if applicable, and a uniform level of cost sharing to all enrollees residing in a specific service area. In short, a PBP is basically a single plan. States can require D-SNPs to offer separate PBPs that enroll different groups of duly eligible individuals. For example, different D-SNP PBPs can be used to serve full benefit duly eligible individuals and partial benefit duly eligible individuals. States and D-SNPs can also use separate PBPs to separate duly eligible individuals who are eligible for a state managed care program or an integrated care program from those who are not eligible for that program due to age or their dual eligibility status, or maybe a nursing facility level of care need, for example. Another example of ways that states and D-SNPs have used separate PBPs is to separate duly eligible individuals who qualify for coverage of Medicare cost sharing as a state benefit from those duly eligible individuals who do not qualify for that coverage of Medicare cost sharing. That separation can be used to help promote clarity in benefits and materials about specific enrollees' cost sharing responsibilities. Use of separate PBPs for different groups of D-SNP enrollees can create a foundation that can help the state advance other enrollment strategies, like exclusively aligned enrollment or default enrollment, for example, because those strategies could be applied to certain D-SNPs, but not others. Slide 20, please. So in the previous slide, I mentioned that states can require that D-SNPs offer separate PBPs for duly eligible individuals who have coverage for Medicare cost sharing versus those who do not have coverage for Medicare cost sharing. On this slide, we've offered an illustration of how using separate D-SNP PBPs to separate those two groups can make the D-SNP materials clearer for each of these two different groups of duly eligible individuals. So in PBPs that have enrollees who owe nothing, if we mix together in that same PBP enrollees who will owe cost sharing when they receive services, the enrollee materials have to represent both of those scenarios, the people who owe nothing and the people who will owe copays or coinsurance. That is what we show in the graphic on the right side of this slide. This can be confusing for both groups of enrollees because the people who actually owe $0 might think that they might owe a copay that they won't owe. And at the same time, people who will definitely owe a copay might think that they're being told they might owe $0 when that's not true. On the left side of the slide, you can see the simplification here of a PBP for only people who will not owe copays, and you can see how much more straightforward that becomes. Slide 21, please. States can use their SMACs with D-SNPs to develop and enforce requirements that will promote integration of Medicare and Medicaid benefits. For full benefit duly eligible individuals, EAE positions states to take advantage of strategies that can help to advance alignment by fully integrating enrollee materials, using single ID cards, and establishing unified appeal and grievance processes. Qualified plans can also use default enrollment to increase enrollment in integrated D-SNPs among individuals who are newly eligible for Medicare. And finally, use of separate PBPs or plan benefit packages for different groups of D-SNP enrollees can help to advance other strategies like exclusively aligned enrollment and default enrollment. And it can also help to promote clarity in the benefits that are being offered by particular D-SNPs, as well as enrollees' cost-sharing responsibilities. Now I'm going to hand it over to Diane, who's going to talk about how SMACs can be used to advance other state goals. Slide 22, please.
Thank you very much, Erin. In this section ahead, we'll explore how states can use their SMACs to go beyond the minimum federal requirements and to drive progress towards state priorities in areas like care coordination, benefits coverage, enrollment, and more. Slide 23, please. At a basic level, every D-SNP must have a state Medicaid agency contract in place to operate, and all SMACs must meet certain minimum requirements. But beyond those minimum federal requirements, states can use these contracts to promote coordination of Medicaid benefits and improve the quality of care delivered to D-SNP enrollees. For example, through the SMAC, states can set expectations that strengthen how plans coordinate care, how they cover and align Medicaid and Medicare benefits, how they support eligibility and enrollment processes, and even how they communicate with enrollees and report data back to the state. In other words, states can use SMAC requirements to align D-SNP operations with a state's broader integration and Medicaid program goals. To support states in this work, the Integrated Care Resource Center has developed SMAC language tools that include both required elements, which all states must include, and optional provisions that states can choose to add based on their specific priorities. Those resources are on the ICRC website at the link shown on this slide. Slide 24, please. Let's dive into some examples now of how states can incorporate additional requirements into their SMACs, starting with care coordination. D-SNP's care coordination processes are central to improving outcomes and experiences for duly eligible individuals, and states can require D-SNPs to take specific steps to enhance care coordination or align care coordination activities with state Medicaid goals or processes. For example, states can require D-SNPs to incorporate state-specific language into the D-SNP's model of care, to coordinate with particular entities, or use specific processes to improve discharge planning and transitions between settings, or even to make sure health risk assessments are completed quickly and include state-specific information. States can also set expectations for those who provide care coordination, such as requiring D-SNP coordinators to have particular training or work directly with Medicaid care managers, such as those managing the delivery of home and community-based services. It's also important to think about timing. D-SNP models of care are typically approved by CMS for up to 3 years, and states can review them during that process to ensure their priorities are reflected. While states can make off-cycle updates, many find it easier to time any new requirements with the existing CMS review schedule. For those interested in more detail, the ICRC hosted a webinar in April 2023 that focused specifically on ways to leverage D-SNP models of care to strengthen care coordination. I encourage you to check it out if you want more ideas of how to use SMACs to improve care coordination. Slide 25, please. Another way states can strategically use their SMACs is by influencing how D-SNPs cover or coordinate Medicaid benefits. Some states, for instance, require D-SNPs to cover certain Medicaid benefits directly, or have them covered through an affiliated Medicaid managed care plan under the same parent company, which makes the enrollee experience more seamless. This could include requiring the D-SNP to cover Medicare cost sharing for enrollees, for example, to reduce complexity for enrollees and providers, or to cover a more comprehensive suite of Medicaid benefits. States can also use SMAC requirements to promote better alignment between Medicare Advantage supplemental benefits and Medicaid coverage. This could include asking D-SNPs to share a list of the supplemental benefits they offer, requiring D-SNPs to ensure that supplemental benefits are used first before Medicaid coverage is used, or requiring D-SNPs to cover certain benefits as supplemental benefits. When developing and implementing SMAC requirements related to Medicare Advantage supplemental benefits, timing is key. Medicare Advantage plans submit their bids annually to CMS on the Friday before the first Monday in June, but those bids are developed months in advance. So states that want D-SNPs to begin covering a particular benefit should alert the D-SNP to that new requirement at least 6 months before bid submission. Slide 26, please. States can also use SMAC requirements to improve enrollee experiences during D-SNP enrollment and support enrollees during Medicaid eligibility redetermination processes. States can require D-SNPs to alert enrollees to upcoming Medicaid redetermination dates or assist enrollees with Medicaid redetermination paperwork to prevent them from unnecessarily falling off of Medicaid benefits. States can also require D-SNPs to provide eligibility deeming periods of at least a minimum length of time to prevent enrollees from being disenrolled from the D-SNP during short periods of Medicaid ineligibility. As Erin noted earlier, requiring D-SNPs to use default enrollment can help maintain continuity and coverage when a Medicaid beneficiary becomes newly eligible for Medicare. States can also define which populations are eligible to enroll in D-SNPs, such as by limiting D-SNPs to full benefit dually eligible individuals, or using separate PBPs for full and partial benefit enrollees. ICRC has resources that walk through these policy options in more depth, including technical assistance tools that focus on redeterminations, deeming periods, and default enrollment. All of these resources are available on the ICRC website, and we've provided links to those resources in the box on this slide. Slide 27, please. Communication and marketing are another area where states can use their SMAC requirements to improve or streamline enrollees' experiences with care. By requiring D-SNPs to submit materials for state review, or by prescribing specific state-approved language to be included, states can ensure that the information enrollees receive about Medicaid benefits is accurate, easy to understand, and reflects state-specific rules and processes. For states with applicable integrated plans, or AIPs, the SMAC can go even further. States can require AIPs to use integrated versions of certain materials, such as the summary of benefits, the evidence of coverage or member handbook document, the annual notice of change, the provider and pharmacy directory, and the list of covered drugs. When a state requires AIPs to use integrated versions of these materials, the state works with CMS to develop integrated templates and then requires the D-SNP to use those templates when issuing the materials. Looking ahead, all AIPs will be required to use integrated member ID cards starting in 2027, another step towards helping enrollees navigate their coverage more easily. As with the other SMAC requirements we've reviewed, ICRC has also has a resource focused on integrated materials, which you can find through the link on this slide. Slide 28, please. Finally, data reporting can be an especially effective tool in achieving a state's integration goals. By embedding strong reporting and oversight provisions into the SMAC, states can collect key data that enables them to actively monitor D-SNP performance, ensure accountability, and drive continuous improvement in care delivery. Through the SMAC, states can require that D-SNPs share information like encounter data, quality measure results, appeals and grievance data, bid information, and even Medicare audit findings or corrective action plans. States can also ask for care management data, enrollment files, or provider network updates, all of which support more informed oversight. The ICRC has developed a robust set of tools to help states design and implement these kinds of reporting requirements and to help monitor D-SNP performance over time. Slide 29, please. Before I hand off to Ryan, who will provide more details about D-SNP monitoring and oversight strategies, I want to share a few key takeaways from this section of the presentation. First, while every D-SNP is required to have a state Medicaid agency contract in place to operate within a state, these contracts serve a far greater purpose than simply meeting federal compliance requirements. They give states a meaningful opportunity to shape how D-SNPs function by improving care coordination, aligning benefits, streamlining enrollment, and ensuring that enrollees experience coverage as one integrated system rather than two separate programs. The ICRC SMAC language tools are a great place to start. They walk through the required contract provisions that apply to all states, as well as provide a menu of optional language that states can adapt to advance their own goals. Those tools are available on the ICRC website, which you can find by clicking the link on this screen. With that, I'm going to turn it over to my colleague, Ryan, who will talk about monitoring and oversight strategies states can consider using to ensure that D-SNPs are meeting state-specific goals and requirements. Slide 30, please.
Thank you, Diane. In this next section, I will talk about strategies that states can use to monitor and oversee the care provided by D-SNPs. Slide 31, please. There are two levels of D-SNP quality oversight that states should be aware of, depending on the type of D-SNPs that the state contracts with. Level 1 involves oversight of CO D-SNPs, which cover Medicare benefits and coordinate the delivery of Medicare and Medicaid benefits. Level 2 involves oversight of D-SNPs that cover both Medicare benefits and at least some Medicaid benefits beyond Medicare cost sharing, such as LTSS, behavioral health, and/or dental. Regardless of the level of integration, CMS and states share responsibility for D-SNP oversight especially when D-SNPs cover Medicaid benefits. CMS is responsible for overseeing the quality of the Medicare benefits that D-SNPs provide, whereas the state is responsible for overseeing the quality of the Medicaid benefits that the D-SNP provides, as well as any compliance with state requirements in the SMAC. In the next few slides, I'm going to walk through how states can use 4 steps to monitor and oversee D-SNP performance and improve coordination or integration of Medicare and Medicaid benefits. Slide 32, please. A first step in examining D-SNP performance is to identify performance improvement opportunities. States can use different data sources to identify such opportunities. For example, states can use quality measure data, such as data from the Healthcare Effectiveness Data and Information Set, or HEDIS measures, as well as member experience survey data. States can also review encounter data or reports about D-SNP enrollees' use of particular services to identify service use gaps, or use appeal and grievance data to identify trends that states may want to understand better. States can also consider requiring D-SNPs to report data in a way that enables the state to identify discrepancies in enrollees' access to or use of services or their experiences with care. A great example of this is to require D-SNPs to stratify data or reports by different subgroups of enrollees. Slide 33, please. Once a state has identified performance improvement opportunities, the next step is to set measurable goals and objectives and incorporate them in the state's SMAC. Goals are high-level performance aims that provide direction for the specific steps to be taken. Objectives are measurable steps toward meeting those goals and typically include specific measures for evaluating performance. For example, a state might set a goal to improve coordination during care transitions with an objective to increase follow-up rates after discharge from hospitals for dually eligible enrollees with behavioral health needs. To inform goals, consider consulting with D-SNP enrollees for input and feedback. To gather this feedback, states can leverage D-SNP enrollee advisory committees, state-level Medicaid advisory councils, or other outreach events for D-SNP enrollee input and feedback. As states work with D-SNPs on oversight, they may want to consider incorporating D-SNPs into state Medicaid quality strategies and aligning goals for D-SNPs with those established for Medicaid managed care plans in the state. Slide 34, please. After setting measurable goals and objectives, the next step is to use Medicaid and Medicare tools to drive performance improvement. There are a number of performance improvement tools available to states. For example, in Medicaid, states use quality assessment and performance improvement programs, or QAPI programs, to work with managed care plans to achieve particular goals. QAPI programs include performance measures, performance targets, and performance improvement projects, also known as PIPs, which aim to improve the quality of care delivered to Medicaid enrollees. States can also use Medicare quality improvement tools to drive performance improvement in D-SNPs. These tools include Medicare Advantage quality improvement programs, as well as Medicare Advantage chronic care improvement programs, which aim to promote effective chronic disease management and the improvement of care and health outcomes for enrollees with chronic conditions. Additionally, states can use D-SNP models of care to pursue performance improvement goals. For example, a state could require its D-SNPs to incorporate specific activities into their models of care that aim to achieve certain quality improvements. States can collaborate with D-SNPs to design and implement these tools and include specific measures and reporting strategies that the state can use to monitor D-SNPs' progress toward state goals. Slide 35, please. States can also use incentives or penalties to encourage D-SNP and performance improvement. Examples of incentives include quality or performance withholds, bonus payments, publicly posting report cards, and allowing only high-performing D-SNPs to use default enrollment or conduct certain types of marketing. Examples of penalties include corrective action plans, fines, suspending marketing activities, suspending new enrollment and/or default enrollment if the state uses default enrollment, and contract termination. Whatever incentives and penalties the state uses should be tied to the measures or monitoring strategies that the state chose to monitor progress. Slide 36, please. The final step is to monitor progress toward your goals and objectives. To do so, states will want to collect data and monitor both state level and D-SNP level performance on the measures and monitoring strategies that the state selected for its goals and objectives. States can implement, review, and customize several Medicaid evaluation tools. First, states can use Medicaid Managed Care External Quality Review, or EQR, which includes specific mandatory and optional activities and is implemented through formal EQR protocols. Second, Medicaid Managed Care Quality Strategy evaluations are less structured than the formal EQR process, and they involve assessing whether the state is meeting its goals and objectives or if further interventions are needed. On the Medicare side, Medicare Advantage plans, including D-SNPs, are required to report the status of their chronic care improvement programs to CMS annually through the Health Plan Management System, or HPMS. States can use their SMACs to require D-SNPs to report this information to the state as well. States may also require D-SNPs to submit their model of care evaluations to the state, in addition to requiring D-SNPs to submit models of care to the state for state review and approval if the state requires inclusion of state-specific language in those documents. States can also collect feedback from enrollees, D-SNPs, providers, and other interested groups to understand the needs and priorities of each group in order to design goals and strategies that aim to address those needs and resolve barriers to goal progress. Slide 37, please. Now that we've talked through D-SNP oversight and performance improvement strategies, we'll now quickly review how requiring D-SNP only contracts can support state oversight of D-SNPs. Some Medicare resources, like Medicare Advantage HEDIS measures, are only available at the Medicare Advantage contract level. Because Medicare Advantage contracts can include multiple plans operating across states, this can dilute the state's ability to leverage these resources for understanding individual D-SNP performance. With D-SNP only contracts, a state can require its D-SNPs to establish contracts with CMS that only include one or more D-SNPs within the state. When states exercise this D-SNP only contract option, it enables the D-SNPs contract level reporting to be specific to the D-SNP products that are offered by a particular Medicare Advantage sponsor within a particular state. Some examples of these contract level resources include Medicare Advantage HEDIS measures and the Medicare STAR ratings. CMS issued sub-regulatory guidance for states in August 2022 regarding key considerations and processes for pursuing this opportunity. If you're interested in this opportunity, feel free to reach out to CMS and ICRC to discuss the process. You can also find additional information about D-SNP only contracts through the links on this slide. Slide 38, please. So how do D-SNP only contracts benefit states? Well, there are several ways that states may benefit. First, most quality measures, as well as Medicare Advantage STAR ratings, are calculated at the contract level. As I mentioned in the last slide, D-SNP-only contracting enables reporting of quality measures and calculation of star ratings specific to each D-SNP-only contract within a particular state. The plan level performance captured in the plan's quality data is no longer diluted by other Medicare Advantage products and becomes more relevant to any state goals to improve quality of care for duly eligible individuals. Second, states with D-SNP-only contracts can access HPMS, which is the system that CMS uses to facilitate health plan data collection and reporting activities for the Medicare Advantage and Part D programs. This access can improve coordination between the state and CMS on monitoring and oversight of D-SNPs, and it provides the state with access to shared materials within HPMS. Third, because models of care are developed at the contract level rather than the PBP or plan level, the D-SNP-only contract option helps states work with D-SNPs to tailor the model of care to address the state's expectations. For example, states can include provisions in their SMACs requiring that D-SNPs ensure that their models of care accurately reflect the full scope of care coordination between Medicare and the state's Medicaid programs and services. D-SNP-only contracts can also allow states to conduct simultaneous reviews of the now tailored model of care with NCQA. Finally, D-SNP-only contracting can provide transparency on healthcare spending, since the medical loss ratio for a D-SNP-only contract, which is calculated at the contract level, will be specific to the duly eligible D-SNP enrollees included in the state's integrated D-SNP program. Slide 39, please. There are several key steps that states should take if they are interested in requiring D-SNP-only contracts. First, states should have a conversation with CMS about their interest in D-SNP-only contracts. The state should then engage all interested parties, including Medicare Advantage organizations, duly eligible individuals, and/or organizations that serve them, provider groups, and others about the state's consideration and intent to implement D-SNP-only contracts. This upfront engagement with relevant stakeholders will provide states with a valuable opportunity to obtain feedback on the state's planned approach and implementation timing. Then, when ready, states should notify CMS and its D-SNP contractors of the state's intent to require D-SNP-only contracts. CMS recommends that states notify the D-SNPs at the same time the state notifies CMS. To notify CMS, CMS requests that the state submit a letter to MMCO that notes that the state intends to establish D-SNP-only contracts and implement integrated materials by a specific plan year. CMS requests that states submit their letter of intent to require D-SNP-only contracts by August 15th of the year that is 2 years prior to implementation of those contracts. For example, a state intending to establish D-SNP-only contracts and integrated materials for the 2028 plan year would need to notify CMS of the state's intent by August 15th, 2026. After notifying CMS and D-SNPs of the state's intent to require D-SNP-only contracts, states should also convey any state-specific model of care requirements, if the state has any of those requirements, to the D-SNPs. D-SNPs will need to submit new models of care that are specific to the D-SNP-only contracts, so the state should make sure D-SNPs are aware of any state-specific requirements ahead of time so the D-SNPs can incorporate them into their models of care. After notifying CMS, states should also start working with CMS to develop the integrated versions of the summary of benefits, the list of covered drugs or formulary, and a combined provider and pharmacy directory. Slide 40, please. I'll end this section with a few key takeaways. First, CMS and states share responsibility for D-SNP oversight, especially when D-SNPs cover Medicaid benefits. Second, states can improve D-SNP performance over time by identifying performance improvement opportunities, setting goals and objectives, applying performance improvement tools, and monitoring performance. Also, states can also use D-SNP-only contracts to gather contract-level Medicare data and quality information specific to the D-SNPs in their state. And now for questions and answers, I'll turn it over to Erin. Slide 41, please.
Thanks very much, Ryan. If you can go to slide 42, thank you, Emily. As a reminder, to submit questions, please click on the Q&A icon, which will be at the bottom of your Zoom screen. All attendees are automatically muted during the webinar, so we'll need to take all questions from that Q&A box. So if you enter your questions there, I'll be able to see them and I will read them aloud to our presenters. And I'll kick us off with one that I got in the middle of the presentation. Diane, this one was from when you were presenting. We had gotten a question about states with the applicable integrated plans, or AIPs. For states with those D-SNPs, what does the process look like for developing and requiring use of integrated member materials like the evidence of coverage or summary of benefits?
That is a great question. So states could use SMAC requirements to require their AIPs to use integrated versions of certain materials, which combine Medicare and Medicaid information into a single document. So once the state identifies which materials it wants to integrate, such as the summary of benefits, evidence of coverage or member handbook, the annual notice of change, or the provider and pharmacy directories, the state should incorporate a requirement to use integrated versions of those documents into their SMAC. The state will also work collaboratively with CMS to develop integrated templates that meet both Medicare and Medicaid requirements. This process will begin a little more than a year before the contract year in which the plan will have to use the integrated materials. So, for example, a state that wants to require integrated materials in 2028 will begin working with CMS on the integrated templates for those materials around November of 2026. Once those templates are finalized, CMS provides them to the plans, and the plans will populate them with the plan-specific content. If the state requires, the plans may then submit the final materials to the state for review before sending them to enrollees. The ICRC has a written tool on integrated materials that provides additional details on this process, including some examples of integrated templates that are used by states. Anyone who's interested can go see slide 27 for a link to that tool.
Thanks, Diane. And I'm going to go ahead and take another question that has come through because it pertains to something I presented on use of separate plan benefit packages for different groups of dually eligible people. The question is that in the presentation, we mentioned the use of separate benefit packages for different groups of D-SNP enrollees, but the question asker isn't sure why a state would want to create more D-SNP plans since the recently finalized rule is aimed at reducing the number of D-SNPs in a given area. So they're trying to reconcile those two things. And that's a great question. And in responding to this, I do want to flag that anyone who wants to learn more about the new rules that this person is talking about, which are the federal requirements at 42 CFR 422.514H. You can go watch the recording of part 1 from this webinar series, which we've provided a link to on slide 12. In the part 1 webinar, we actually covered what those new rules do and which D-SNPs they apply to in detail. But in referencing those new rules, I want to clarify that the goal of those new rules is to simplify D-SNP options for full benefit, duly eligible individuals, and to promote greater alignment and aligned enrollment between D-SNPs and affiliated Medicaid MCOs. So the rules aren't necessarily inherently aimed at reducing the number of D-SNPs overall, but rather at reducing the volume of D-SNP options that a particular full benefit duly eligible individual may have. And so it is possible to require use of separate PBPs for different groups of duly eligible individuals without actually increasing the number of D-SNPs that a particular individual would have available to them. And so, for example, there's an exception in these new rules at 422.514H that allows a parent company to offer multiple D-SNP PBPs in a particular service area if those PBPs enroll different age groups of duly eligible individuals, for example, or if those different PBPs otherwise align with the benefit design used by the state in designing its Medicaid managed care program, for example. So that really sets states up to be able to continue to use these different D-SNP plan benefit packages to serve different subpopulations of duly eligible individuals, even while these rules are being implemented. I do also want to note that the new rules that I'm talking about really apply to D-SNPs that enroll full benefit duly eligible individuals. So when we're talking about carving partial benefit duly eligible people into their own PBPs, that can still happen. And those D-SNPs that only serve partial benefit duly eligible individuals will not be affected by those new rules. We are here, though, to help individual states think through, if you're thinking about possibly trying to use separate PBPs to serve different groups of duly eligible people, we're more than happy to have a detailed conversation with individual states about your options and what might work best in your particular environment or to achieve the particular goals that you're interested in achieving. So thanks for that question. Ryan, we've also got a question here that I'm going to throw to you, which asks what role the state plays with enforcing SMAC requirements versus the federal government. Is there any kind of limitation on what a state can enforce if it overlaps with what CMS enforces, for example?
Aha, that's a good question. And thanks to whoever submitted that. So because the SMAC is a state contract with a D-SNP, state Medicaid agencies are responsible for enforcing all of the state-specific requirements that they put or include in their SMACs. State CMS has oversight responsibility for requirements that CMS imposes on plans, such as those that are stated in federal regulations. And CMS will take the lead on overseeing compliance with those requirements. When a state incorporates requirements into its SMAC, the state requirements cannot contradict CMS rules and federal statutes. However, states can build on CMS rules to require D-SNPs to, let's say, take actions that are more protective to an enrollee than what is required under federal rules. If you take an example, federal rules require that D-SNPs conduct a health risk assessment, or an HRA, with each enrollee within, I think it's 90 days of enrollment. A state could use its SMAC to require that D-SNPs conduct those HRAs within 60 days of enrollment, for example, because that's more protective to the enrollee. It builds on the federal standard. That said, a state could not say that D-SNPs can take up to, for example, 120 days to conduct HRAs because that's less protective than the CMS requirement. So when setting goals or designing monitoring processes, states can reach out to ICRC for help when thinking through what the state wants to achieve and how the state might be able to best achieve those goals and monitor D-SNP performance and compliance.
Thank you, Ryan. And with that, I think we're at time. So Emily, if you don't mind advancing to slide 43, I will go ahead and wrap us up for today. Thank you all very much for participating in today's webinar, and thank you to all of our presenters today. If you would like to revisit today's conversation or the slides, we will be sending the recording and the slide deck from the presentation out to all attendees in the coming days, and we will also be uploading them both to the ICRC website as well. I'd urge you all to visit that website where you can find links to past webinars and written technical assistance tools, and you can also submit TA requests. We hope that this webinar has been valuable for all of you today. And if you are logged into the Zoom, we'd also really appreciate it if you would complete the survey that appears at the end of the webinar. We're looking forward to reviewing your feedback and making any changes to future webinars that might be appropriate based on that feedback. We'll also send that survey out via email when we send the recording and the slides after the webinar too. So please, please, please respond. And thank you all. We hope you have a great rest of your day.